Today, we're going to be talking about treatments for HS, specifically medical treatments for HS. We have Dr. Jennifer Hsiao here with us, and then later we have patient advocate Mario Otero, who's going to be joining us to talk about his experience with clinical trials. Now, I know that this might be a touchy topic for some people, but I am about, and AHSID is about, making sure that we provide as many options as possible to patients for you to make your own choices. So that's why we're talking about clinical trials, because without clinical trials, the treatments that we need to manage our symptoms and improve our quality of life can't be created, right? So we want to provide perspective from a patient. And this is not just about talking about the positive, but we're going to talk about everything in between, okay? So we're going to give you a 360 view. I was going to say 180. That's a half a circle. So a 360 view of clinical trials and treatments for HS. We have our sponsors, which we want to give a quick shout out to UCB, My Magic Healer, Hydraware, Designs by Muriel, and then also Burt's Bees. Thank you so much for donating to us and making this event possible, because without you, we would not be here. And also all the attendees, without you, we also would not be here. So thank you so much for everything that you do. Without further ado, I want to welcome Dr. Hsiao to the HS Awareness Week Virtual Summit Day 2. Thank you so much for joining us today. We know you could have been anywhere, but thank you so much for being here.
Thank you, Jasmine, for having me. And hello to this wonderful HS community. It's an honor to be able to come and speak with you all today, and can't wait to be joined by Mario later so that he can share his perspectives as someone who has actually gone through a clinical trial and his experiences with that. I'm just going to start first going over an overview of medical treatments for HS, and of course also highlighting exciting and new things that are on the horizon. I feel like in recent years there's really been more research and more attention being paid to thinking about what new treatments may be helpful and safe. And so I really do feel like there is hope that we can find treatments that are, good from an efficacy, but also a safety profile, like ones that we feel comfortable with our patients being on long-term and hopefully having long-term benefit from as well. So to get started, and also if anyone at any point can't hear or the sound goes off, please put it in the chat or Q&A to let me know. So just to introduce myself briefly, so I'm at the University of Southern California. I run an HS clinic here. I'm at both the county system and the private system. I also am getting clinical trials for HS established here. I also have a Hope for HS virtual support group that I run for Los Angeles. And I've teamed up with UCLA and UCLA Harbor physicians for that as well. And I'm just really excited to be here. So thanks for spending some time with me today. So a couple of things I wanted to also just discuss. I am on the board of directors for the HS Foundation, which is a nonprofit organization whose goal is to move the field of HS forward from research, treatments, advocacy, and awareness. I also did edit or was an editor for a comprehensive textbook on HS that came out in 2022. I also do a variety of different things with different companies that are interested in trying to find new therapeutics for HS, and that could be in the field of like trial design or actually investigator for a trial, et cetera. And I'll be showing you, some of the things that are coming down the pipeline. So just to get started first, I just wanted to show some photos. When we talk about HS, and I mean, I don't really tell you this, but people can have different severities of HS in terms of, are there scars? Are there tunnels? Are there large lesions that keep recurring? Is there an anatomic area that's completely sort of taken up by lesions, or is it just sporadic here and there? And things like that help us when we're thinking about what treatments to try to start. And I think a large part of it too is right now, at least for medical therapies, which I'm going to be focusing on today, because there's going to be a session on surgical treatments that because Jasmine invited Dr. Goldberg, who will be speaking later this week. really one of the things to note is that medications, at least currently, really can't make tunnels and scars disappear. So when we talk about treatments and medical treatments, it's really more about, how often does somebody get new lesions? Can we cut down the frequency to which new lesions come up? Can we cut down on pain and drainage? If lesions come, will they be smaller than they were before? Will they happen? Will they last for a shorter amount of time? So I kind of think of it in terms of flaring too, like trying to decrease that severity, frequency, and duration of flare versus, having someone think that their tunnels are all just going to disappear, because right now, again, medications don't really make structural things like tunnels go away. That really requires more procedural therapies, but drainage from tunnels, that medications can help with. And one thing I always like to say too is, as of right now, there's no single best path for anyone. I think, when someone comes to see me and they're sitting in the chair across from me, it's important to gather different goals that, the person living with HS may have. It's important to think about, what are reasons why you might start one treatment versus another. So a lot of times it's a journey and a lot of patience is required. And I already saw in the chat, right? Like a lot of you were saying that you feel like you've tried so many treatments, none of them seem to be working. And you almost feel like things are just, like a guinea pig almost in that sense. My hope is, as more effective treatments come, that happens less and less. And it's going to be more about like being able to find a treatment earlier on in the journey that's helpful, and hopefully being able to stay on it and have it continue to be helpful. Also, HS doesn't really just affect someone in the skin necessarily. There are lots of other sort of, clinical conditions. For example, people with HS may have a higher risk of diabetes or high cholesterol and high blood pressure. And I think part of that is just related to the fact that HS is a condition that has a lot of inflammation. And that in of itself can cause these sort of metabolic or like cardiovascular heart type implications. And so from my perspective, besides just treating the skin, it's really important to make sure that y'all are plugged in with a primary care doctor who's really good at screening and making sure that your whole health is being taken care of. And it's not just an emphasis on, how the skin lesions are looking, but your, physical and mental health as well. When we think about HS, and, I think this goes to the question of like, what causes HS? And the fact that it's still under investigation, we think it is, due to the hair follicle. And there's excess of inflammation that's definitely been seen. But, for some people, there's like a genetic predisposition. Up to 30 to 40% of people with HS will say that they have a family member with, HS that they are aware of. There's also, friction seems to make things worse, sweating or heat. And so I think there's different pathways to HS, and I wrote them out here. And I think it's helpful to see, because the treatments that we have often will target some of these different pathways. So for example, a lot of my female patients will tell me that their HS gets worse before their period. And if that's the case, there are treatments that can target that hormonal drive for HS. Others will say that they don't feel like there's a hormonal component at all. So I think part of the challenge is trying to figure out, which arms can we target with different therapies to try to get the best combination of treatments possible. And there are official guidelines that have come out, treatment guidelines for HS. These are the North American ones. And it's a very busy slide. So I just wanted you guys to know that there are guidelines out there that hopefully providers who are taking care of patients with HS know about. There's also updates that are needed to it and new research coming out all the time. But you can just see on the list here, medical treatments, procedural treatments, things to do when there's flares. There are definitely options. And so we'll just go ahead and jump right in. So thinking about the difference between treating somebody who has maybe a lot earlier mild HS versus someone with more moderate to severe. So we're going to cover some mild HS treatments right now. So starting out with some lifestyle modifications. So I definitely have heard, and in the literature, it's been reflected that like really tight clothing or friction or rubbing of the skin can cause HS to worsen. And so, not wearing the tight-fitting clothing, trying for more loose clothing, soft fabrics, cotton, bamboo, etc. Smoking cessation I put here. There is a higher rate of smoking among people living with HS. There have been some papers suggesting that perhaps with smoking, certain treatments may not work as effectively. But I think for overall health, it's just good to consider that as well. Although I understand that it can be very difficult to quit. Sometimes it might not be the right time to consider, but just something to always just have in our minds as something that can help overall health as well. Wanted to also talk about oral zinc. I think there's just a lot of information about supplements that's out there. And the supplement that has the most rigorous scientific data behind it is zinc. The main side effect is really GI distress, but taking it with food can help. Taking too much zinc can actually cause someone to be deficient in copper. And so because of this, taking zinc with a little bit of copper, sort of in a 10-to-1 ratio may be helpful. So for example, if you were to take 100 milligrams of zinc, to have 5 to 10 milligrams of copper as well. And the studies have shown that for patients with mild HS, oral zinc supplementation may be helpful in improving their condition. So what topical things can be used for HS? Probably many of you on the call are familiar with clindamycin topical. I feel like that's one of the most popular go-to medications for HS. So clindamycin 1% topical, there's the gel, lotion, and solution formulations. Resorcinol is another topical I wanted to mention. It's a phenol derivate, so it kind of it causes the skin to sort of get thinner and peel a little bit, and it's anti-inflammatory. So the goal of resorcinol is to put it on those inflamed nodules or bumps that are coming up, and they're painful and they're active because they're red, they're growing. Resorcinol ointment once or twice a day on it can help them shrink and can be helpful. So that's something you could potentially ask your provider about if you haven't tried it. Although of note, unlike clindamycin, where you can just head to your local pharmacy to pick it up, resorcinol topical does require a compounding or specialty pharmacy. So that's something just to be aware of as well. Topical steroids have also been used, especially when HS lesions are inflamed or itchy. And then also just using an antiseptic wash a couple times a week, like Hibiclens, chlorhexidine, or benzoyl peroxide wash. And the thought there is also, HS is not an infection, right? It's not contagious. It's not because, you have like an active bacterial infection that you need to like kill the bacteria, but it could be that certain bacteria living on the skin are causing an abnormal inflammatory response. And so these sort of antiseptic washes, if they can reduce the level of those types of bacteria, maybe it can also help decrease the ensuing inflammation. Antibiotics originally, sort of like maybe 5-10 years ago, I feel like it was absolutely one of the mainstays of treatment for mild HS and also moderate to severe HS. And again, it's not even necessarily because you're trying to kill bacteria, but more because a lot of these antibiotics also have anti-inflammatory properties. The microbiome, like the types of bacterial community that lives in HS lesions or on the skin of people with HS, has also been found to be different from those from people without HS. So there's probably something going on with the microbiome and with bacteria. It's just unclear exactly what role it's playing. But, I'm sure many of you have tried antibiotics and probably gotten some relief from them. I've listed out some that, we use in clinic, and there's also data for sort of like combinations of different therapies that have been used. So what I would say is, antibiotics, they're medications that can help. They can help when somebody is flaring, but certainly, it's not really a good long-term option, right? Like I wouldn't want my patient to take antibiotics for years and years and years. Antibiotic resistance, probably causing some nausea on the gut and stomach. So the goal is really hoping that there can be other options that we can look for and use antibiotics only when needed. I also wanted to talk about some other options. So there's also hormonal and retinoid therapies. So as I mentioned earlier, for female patients that flare, and we did a survey, and really for women of, women who get their periods, over 60% said that they'll get HS that worsens before their period, like the week before typically, some during. And in those cases, spironolactone or a birth control pill can actually be very helpful to try to decrease hormonal flares. And I have some patients where it was so hormonally driven that really by doing, some topicals, some, trying to avoid triggers and being on one of these hormonal therapies, they've really been able to achieve pretty good control. So really depends on how much of that hormonal component is there. For male patients, finasteride is a medication that has some data behind it. Actually, is also used often for sort of male pattern hair thinning. It's also known as Propecia. And then for both female and male patients, metformin, which is actually a diabetes medication, but they did some studies looking at metformin in patients with HS, even without diabetes, and found that there was some improvement. And so for somebody who has maybe pre-diabetes or some insulin resistance signs, I think metformin could be something that could try to cover two bases. HS and also sort of the insulin resistance diabetes, if that is something that's there. And also considering an oral retinoid. So oral retinoids, really sort of a mixed result in the literature. There's some reports that it helps. There's some reports that it has actually worsened HS. And then for others, it hasn't seemed to make a big difference. So I would say it's something to be considered in certain circumstances. So for example, if someone has really, really severe acne and it's really bothersome and they've tried other treatments and they're thinking about doing an oral retinoid anyway, and they have some mild HS, I think it'd be fair to try it and say that we'll see what happens to the HS, but you may need some other therapies as well. And then also there's some antiperspirant strategies. And the reason I'm mentioning this is also because summer is sort of around the corner, and I have patients who are definitely nervous about summer, saying that, when the heat comes and they start to sweat more, they know that's when their HS gets worse. And we've actually looked at some of the data, and it suggested that when it's summertime, that's when urgent appointments for HS will go up, even sometimes like urgent care visits, right? Like, just to me, that implies that for patients, there's probably something either in the sweat, or there's like sweat and more friction or the heat that's causing HS to flare more, and people need to seek more care. So what are some things that can help? So there's some topicals that are prescription that can help decrease sweating. There's also some pills that can be taken, but some of the side effects of the pills, as you can imagine, if you're going to decrease sweating, you might get some, for example, dry eyes, your mouth might be a little bit dry. And then also, interestingly, botulinum toxin, also known as Botox injections, has been shown to potentially be helpful. And certainly for excessive sweating, for example, in the armpits, doing these Botox injections can help reduce sweating, and then may also help with mild HS as well. So just wanted everyone to be aware of that. And then now we're going to dive into what to do and what to think about when there's more moderate to severe HS that's there. And I'm talking like, maybe there's more scarring that's coming after the lesions, recurrent, abscesses and nodules that are painful, not well controlled with your current therapies, or, there's tunnels that are draining, et cetera. So certainly there are now treatment options to talk about. And I think a key strategy really is to get after the inflammation that's driving and perpetuating these lesions. So here is a slide right now that's talking about the different biologics that are sort of available. And I wanted to just have the slide here so you can see that there are definitely more options now for treatment than there used to be. And so a biologic is a type of medicine that really tries to target an inflammatory molecule and sort of bring it down. So they've measured the levels, for example, of certain inflammatory markers, both in the skin lesion and then also in the blood of people living with HS. And so there's some called TNF alpha, for example, or IL or interleukin 17, 1, 1223. So these markers have been found to be high when they've looked at actual HS lesions themselves, and then also when they've looked at the blood of people with HS compared to people without HS. And so in using one of these medicines and sort of blocking these inflammatory markers and lowering these inflammatory markers back down, the trials, data, et cetera, and just seeing my patients improve, for a lot of people, we can see decreased inflammation showing up as decreased pain, fewer flares, less drainage, et cetera. So adalimumab, also known as Humira, the brand name, is a TNF alpha inhibitor, and it was approved by the FDA in 2015. So since 2015, it's basically been the one that's been on like insurance formularies, for example. It's actually had 2 large phase 3 meaning that it's the trial that has hundreds and hundreds of patients meant to see if there's benefit compared to placebo getting injected with, just, nothing at all versus active medication, Humira, showing benefit. And as Jasmine mentioned earlier, there's actually adalimumab biosimilars that have been hitting the market. So what is a biosimilar? A biosimilar is a medication that's very similar, hence the name. It's very similar to the medication that it's sort of like copying. So it's just like adalimumab, except there's like a tweak in it, the molecule, that makes it not exactly adalimumab. And so they've already had adalimumab biosimilars in Europe, but this year was when we're seeing it in the United States. And the idea behind biosimilars is that, it's not branded the way Humira is. And so is it easier and more affordable for patients to be able to access it? And so, I think anything where patients have easier access to medications, like I think that's a win. So I'm really hoping to be able to see that play out. And I've spoken to some of the companies behind the biosimilars and told them, because I don't know if some of you are on Humira or have access there, like there's a lot of like patient assistance type websites that help people in terms of having like sharps containers or the ability to like let them know if a pen misfires or something. So I've been trying to push for making sure that biosimilars can have similar types of support for people who are on them. So, and I would say that most people who go on adalimumab, most people have at least some response. I think the issue becomes, what do you do if your response is not exactly what you want, or your response was great, but then it starts to peter. And so that's why I have these other medications listed. And I want you all to know that actually these medications that are listed, they're not FDA approved. The only one that's FDA approved right now is adalimumab. However, because we know that we need these medications in order to treat people, oftentimes with appeal letters and things like that, clinicians are able to get these medications approved. It can be a battle, but I saw in the chat that some of you are potentially getting switched to things, et cetera. So that's where it comes from. So infliximab is also a TNF alpha inhibitor. So it's in the same class of medicines as adalimumab or Humira. Infliximab is also known as Remicade, and there's also some biosimilars for infliximab, and these would include medicines like Inflectra, Avsola, or Renflexis. There's like different biosimilars for infliximab that are already out, and some papers have been published that have looked at using some of these biosimilar infliximab medicines in people with HS and seen that results were equivalent, or, as you would expect, there wasn't a difference compared to the brand name Remicade, which is of course what we'd want to see. So infliximab is different from adalimumab because adalimumab is given as a pen that you inject yourself at home, typically every, say, 1 or 2 weeks. And then infliximab is an infusion. So you'd go to an infusion center, typically between every 4 to 8 weeks, and you'd sit for the infusion to go through over a certain number of hours, between 2 to 6, usually, I would say. And then in some cases, home infusions can be set up. A lot of this also depends on what a particular person's insurance will allow them to do. And then I wanted to mention also secukinumab, because secukinumab, exciting data for it. It is an interleukin-17 inhibitor. So it's a different inflammatory molecule compared to the TNF. So it's a different class from adalimumab and infliximab. But recently they showed that in 2 large trials with over 500 patients in each trial, people who are on secukinumab, also known as Cosentyx, did better than those who were on placebo or no medication. And because of this, the hope is that perhaps secukinumab will be the second medication to gain FDA approval, maybe even this summer. And, you know, I have people in my clinic who are already on secukinumab, but the hope would be that it would be a lot easier to access. Once medications have FDA approval, it's just a lot easier for patients and clinicians to access them. So that's exciting. Other biologics to consider, I think I saw someone in the chat earlier mention something about ustekinumab or Stelara. So again, there haven't been large trials with ustekinumab or Stelara, but there have been smaller studies, you know, collections and cohorts of people who have tried it, who have shown some benefit. And so I would say that as of right now, I don't think we're going to see FDA approval for ustekinumab anytime soon, but it certainly is a biologic that can be considered. And ustekinumab is typically, I'll give an example, for psoriasis, ustekinumab or Stelara is often given every 12 weeks. But in HS, where really I think the data suggest, and the experts would agree, in HS, the inflammation is just higher. Typically for ustekinumab or Stelara, you would see the treatment probably every 4 to 8 weeks, so more frequent, so that people who are, let's say, doing okay on it, but they flare before that 12th week, they're able to, you know, get it before they flare. Anakinra, I'm not sure if any of you have been on that or heard of it. It is an interleukin-1 or IL-1 inhibitor. Again, a different inflammatory molecule that's in the inflammatory system net of our body. Anakinra has some small studies showing that it's been helpful. I think one of the harder parts about anakinra is that, unlike the other ones I've spoken about, it's a daily injection. So I feel like that's a little bit you know, harder to get used to, and but certainly in certain cases could be another one to consider. I've italicized 3 of the medicines: guselkumab, risankizumab, and tildrakizumab. Those are italicized because they're all interleukin-23 blockers. But there were trials that looked at 2 of them and found that there actually wasn't a difference between being on one of the IL-23 blockers versus not being on active drug. And because of that, I don't think we're going to see FDA approval for any of those anytime soon. I will say the reason they did the trials in the first place is because there's literature supporting that there's some benefit for these. There's definitely some case reports of, you know, stories basically that are published of clinicians who tried these, probably in people who weren't able to get or weren't able to tolerate or lost efficacy or didn't have a response to the other medicines mentioned. And there are some success stories. So I don't think that just because, you know, the trials didn't show the difference, it means that you would never reach for it again. I just think that it probably wouldn't be the first one you would reach for. And so some key updates, I wanted to mention that there's good data in the literature now talking about adalimumab and infliximab sort of at higher doses than we would originally think about using. So for example, adalimumab is prescribed or it's FDA approved to be used 80 milligrams every 2 weeks. there are some studies in the literature showing that if you go to 80 milligrams weekly, you may be able to improve response or gain back some of the response that you may have lost. But at least up to where the studies have been published, they didn't notice an increase in side effects. And so I think that that's helpful to know because, if someone's doing really well and tolerating adalimumab well, but maybe they just lost some of the good response. It's just like not quite as good as it was before. I think considering increasing the frequency is not unreasonable. And then for infliximab, same thing. There have been, studies going out showing that infliximab, you can get that infusion every 4 weeks, and it can be helpful and up to higher doses. And I think that one of the benefits of infliximab is that, as a clinician, it's easier for me to write down the dosing strength and also the frequency, and kind of tailor it more to how much I think the patient may need. So that's one benefit for sure. I talked about how secukinumab or Cosentyx had the successful 2 phase 3 trials. And you'll see it's because phase 3 trials, the large ones, they're usually done in parallel with 2 of them because they want to make sure that, the results can be replicated. And you submit the data from both those trials to the FDA to see if you can get approval. Bimekizumab is another medication. It's an IL-17A and F inhibitor. So again, one of the sort of IL-17 class medications, except the difference is that it blocks a little bit more, another subset of IL-17 compared to secukinumab. And it also showed that it had 2 successful phase 3 trials. So it's possible that we might see bimekizumab getting FDA approval later this year as well. And I'm just thrilled because I just want more options for my patients. And I want to see more medications, be able to demonstrate that they're beneficial and enter the realm where I can prescribe it and get it for my patients. There's also some large JAK inhibitor trials underway. JAK inhibitors, they're small molecules. I'm sure many of you have heard of like prednisone or systemic steroids. The idea, like a lot of times with prednisone, it's thought of as more like, unlike more of the targeted, like you're bringing something down, a specific marker. It's more like a little bit more broad. So a JAK inhibitor, it doesn't have the side effects of prednisone, which is why we don't use prednisone long-term, which, prednisone can cause like eye damage to the stomach, like bones, et cetera. So JAK inhibitors are also broader sort of immune medications that calm the immune system. And also they're given as pills as opposed to an injection. The other 2 mentioned were injections. And so there are some phase 3 trials with JAK inhibitors underway. And I think that, Mario is actually going to be speaking about his experience in one of these trials. And I think for me, it's nice to also have different ways to take medicines. It's nice to have oral options. There may be some people where injections are just very, very difficult. And having the ability to offer something that's not an antibiotic, but can still be taken in pill form is very helpful. So what are some emerging therapies? So this is really exciting. We have a lot of molecules that are actually being targeted right now and in trials. And my next slide will show you sort of the increase in clinical trials that has been taking place. And as Jasmine said earlier, the more clinical trials there are, the better shot we have of trying to find, effective therapies. And I think it's nice to have options too, because right now there's not really a medication that I can say like, this for sure is going to 100% work in you. I think that's why there is that we're going to need to try it. We'll need to reassess. And I think the closer we can get to the majority of people in a trial having an amazing response, I think the more amazing it'll be. So here's a graph of what things have looked like from a clinical trial perspective. You can see in 2010, just a little over 10 years ago, really not that many. And just the number that are active or recruiting or closing, but they're working on analysis, it's just been going up. especially I would say probably over the last 5 years. So it's really exciting, and I'm hoping that, good things come out of this. Briefly wanted to talk a little bit about pain and what can be done. So the goal really is with helping with the inflammation of HS with one of those medications we talked about. Could that help with the pain? That would be amazing. But other ones I have listed here, like acetaminophen or Tylenol, ibuprofen, draining large abscesses, intralesional steroid injections, you know, also neuromodulatory medications, opioids, pain specialist referrals may be done. And really, again, like with the asterisk, we want to treat the HS. We want to think about wound care as well. And also sometimes physical and occupational therapy can be helpful too. Very briefly, procedural management. So Dr. Goldberg, my procedural counterpart, is going to be talking about this. But, intralesional steroid injections into the lesions for really large abscesses that look like they're going to just rupture, just to drain them so you can relieve the pressure. Again, injecting the botulinum toxin or Botox, different forms of laser therapy, like laser hair removal, for example, and then also de-roofing or cutting it out, cutting out like a tunnel, for example, or like tunnels that are grouped together. Some questions that might be helpful to ask your healthcare provider is to help guide your care is to ask, what are things that I can do at home to treat or prevent HS flares? And what are good, treatment options that you think could work for me, and risks and benefits of the different ones? And then, of course, always asking too, like, when should I come in for a follow-up visit? These treatments need to be monitored. And, after you are on a treatment, I would say, especially with the biologic agents, it can take some time. It's not like you have your first injection, you'll necessarily feel different right away. But I would say by around 3 months, it'd be good to check in so that your provider can know, like, is it doing anything? Is it helping at all? Has it done nothing? So making sure you have good follow-up is good. Really a multidisciplinary approach. I think dermatology really is at the center of it. We're very comfortable with prescribing these types of medications. At least all of us should be. And then also in blue up top, primary care, I think, is key. And for other conditions, you may be seeing other doctors who are also part of your team, but two of the top ones, I think, primary care and dermatology, to help with HS and other conditions that might be associated, is really important. Just wanted to write down some helpful support that we have out there. Again, thank you to Jasmine for inviting me today. I can't wait to answer some of your questions after Mario comes on. And then there's also Hope for HS, HS Connect, and the International Association of HS Network. I just wanted to mention, there's also HS Warriors. I wanted to mention for Hope for HS, different regions have support groups. So for example, I run the Los Angeles support group, but it's virtual. So it's really open to anyone who wants to log in and join. Also really exciting, actually just this week, we launched an HS patient guide. It's a free comprehensive educational resource. And we also have an HS app that's coming soon, actually, to help people with sort of tracking flares and response to medications, trying to identify triggers and allowing people to input data and generate, like, for example, a one-page PDF to show their providers how they were doing. Because a lot of times I see people and it's been 3 months, and it'd be helpful to see, what actually happened during that time, because it could be a good day when I see them, but they were actually having a lot of flares. And then also this guide also has excerpts from people, patient advocates, and can answer a lot of other questions you may have about treatments that I didn't get to cover today. So another plug for the HS Foundation. You can definitely check out our website. Our vision is to live in a world where no one suffers from HS, and really just an amazing organization that has scientists, clinicians, also patient advocates, really trying to work together to advance HS and fund research. We also, on our HSF website, we have these templates that were created to allow clinicians to easily download a letter of appeal to insurances when they deny the medications that we, would like to prescribe. So that really makes things easier for clinicians too. So thank you.
It has been a joy to have you. I want to introduce Mario Otero, who is a patient advocate. He is going to talk to you about his experience with clinical trials, because we touched on the medications and treatments, and I think it's important to also talk about patient experiences in clinical trials. So welcome, Mario. Thank you so much for joining us. So let us know who you are and about your background with HS
Yeah.
and clinical trials specifically.
Yeah. So again, my name is Mario Otero. I live in Atlanta. And I've had HS probably for about 23 years. I really didn't know what it formally diagnosed about 2012. So like most of us, I've, the usual suspects of medications, Humira, Remicade, all the antibiotics that you can think of, et cetera. And about 2.5 years ago, 2020, no, almost 3 years ago, I had kind of run out of options of treatments that was available commercially. So my dermatologist recommended a drug trial for an experimental medication of a new, not a new drug class, but new for HS. And, quite honestly, I didn't have much of an option because I just didn't have any other choices. And I was just really, really in bad shape at that point. So just kind of blindly had no clue what a drug trial was all about. It's pretty wild, to be honest with you, because it's so strict, just to be candid. It's a big time commitment. However, like during the whole process, I felt like I was doing something for the home team, if that makes sense, for the community, knowing that, hey, there's 220 other people that are going through this, that I'm going through right now. And it worked really well. Like my body responded amazingly. I mean, it was kind of a game changer. Like my quality of life improved. But it was tough. I mean, it's long, the appointments are long. You get compensated. In my case, I did. But it's draining. It's just a lot of emotions, especially for me, because like I said, I got there and there was nothing else that was working. So I had all my eggs in this basket. And thank God everything is going good right now. And I think it's a part of our treatments that maybe aren't spoken enough about, or maybe not enough awareness, because there's over dozens and dozens of trials right now. I looked on a map, it's pretty much all over the US, globally for that matter, but here in the US, I mean, almost every corner and in the middle of the country, there's good access to these trials. So kind of long-winded, but yeah, so that's in a nutshell. That's kind of it.
Thank you so much for sharing your story. I want to ask you a question.
Yeah.
So why would you recommend for patients to participate in clinical trials? From your personal experience, what was the benefit for you, if there was any at all?
Well, so great question. Very good question. So there was anecdotal evidence, according to my doctor, on the class of medicines that I was taking, that there had been some good responses in like some earlier studies, right? And the fact that I had, failed Humira and Remicade and Taltz, those, I think maybe Cosentyx as well. So, and again, Yvonne, I mean, Jasmine, I was just in such bad shape, that I just, I didn't have any other option. But it was a hopeless feeling at the beginning, for sure, because you can't take any kind of medication for 4 months. In my case, like a washout period. So my HS just went rampant for 4 months. So, and that part of it, it was difficult. Yeah.
What do you do in cases where you're in a clinical trial and this is a trial that is going on for months and
Yeah.
sometimes years?
Years. Yeah.
The restlessness that's involved with that and just sticking to something like that long term. Have you experienced that? And what have been some things that have helped you to stay in it and to trust the process?
Yeah, no, that's a great question. So I journaled, right? I did a lot of writing and took a lot of pictures. So, I mean, I was kind of borderline OCD on the pictures, 'cause I was so interested in seeing how the progress was going. Um, the only thing that really, I mean, it was the most important thing is that the medicine was working and was working really, really well. And I just felt that I was part of something pretty cool. I know it sounds kind of corny. But when you're one of just like I said, there are like 200 people that are going through this, and the way I was looking at it, it was, man, this is going to do so much good for the community once it's approved. And to be a part of that was just pretty neat, to be honest. And it also helped that it paid me $250 a visit. So there is a component to that, not to be completely on the moral high ground. So
There are incentives.
yeah, for sure.
I know that, patients have issues, and just people with HS, because not everybody that has HS is a patient, but people who are living with HS will, like we discussed this a little bit, Dr. Hsiao mentioned this, we feel like guinea pigs in this process.
Yeah.
There are times that feelings come up that are so overwhelming. We have things that are going on in our lives, and we're just like, you know what? I was interested in this, at this particular time, but now that I've spent time in this clinical trial, I don't think this is for me anymore. I don't like this.
Yeah.
I'm not seeing the results. This is making me uncomfortable. Have you had that type of experience? What were some of the emotions that came up, and what did you do in that situation?
God, that's a great question. I remember my very first appointment, and when I said I had to sign like a novel, I mean it was like 200 pages of things I had to sign. It became very real that for the next X amount of months, the pharmaceutical company was really going to be driving my treatment decisions. And it was something I wrestled with in the moment, but I didn't have much of an option. My doctor had been mentioned to me about drug trials for a while, and I was like, I didn't have the time for it, and I was in a period of disability, which really helped, for that time commitment. But it was in that moment, right? And there were periods during the drug trial specific to the protocols that I was in. For example, I couldn't take the medications that I would normally take. I couldn't have a lot of these areas opened up or treated the way I had in the past. So you just had to gut it out. Just because I wasn't having them at the appointment didn't mean I didn't have them. I tell people it took me from a 10 to like a 5, right? A 50% decrease in my HS is huge in that regards. So yeah. And it's just, there's a light at the end of the tunnel, and it was just those first like 6 months when the medicine was kind of barely working, just enough to like help. But I mean, it was brutal those first 4 months. Yeah, no doubt.
Thank you for that. I want to ask you
Yeah.
one last question from
Yeah, for sure.
from me personally.
Yeah.
What piece of advice would you give to patients who want to get into clinical trials or are apprehensive about it, or are in your shoes, have tried a few clinical trials, not good, not bad, it was just meh, what type of advice would you have?
I think first, talk to your doctor, right? Get their opinions. Secondly, I'm a big, believe that you have to advocate on your own behalf, right? So there's hsconnect.org has a whole page of just drug trials. And just looking through there and just making phone calls, I think that's the biggest part is, for me, like I had surgery, right? Surgery was effective, but my HS is on my back. So it's like a big surface area. So it's not practical to do surgery on all over my back. But as I've added this in here, like if I go back, I wish like 5 years I would have got involved in a clinical trial. Maybe I would have stopped my HS from progressing so bad. But I would say just ask a lot of questions, be curious about it, and know that even if you're hesitant, just talking and asking questions, maybe find something you didn't know before. And if you're on the fence, just do it. I mean, you got to give up your biggest resource, which is time, but it's, and it's worth it. It was for me, for that matter, because I'm in a much better place today than I was 3 years ago.
Thank you so much for your experience and your perspective. I want to get into the Q&A. Dr. Hsiao, is there any effective treatment options that would be best for adolescents with HS?
It's a great question. And I think that, perhaps people on this call had HS as an adolescent. I think adolescence, as we know, it's such a vulnerable time. You're like a teenager, just trying to go to class and fit in with your friends. And I just think that this can be something that's so derailing. So I'm always of the mindset, like, it's better to hopefully diagnose early and treat early, so that we can keep people going to school and participating in activities they want to. Um, Honestly, for adolescents, if by the time I see them, they're already moderate or severe, I have the discussion about the biologic already, because we have used biologics for other conditions, like if somebody has early Crohn's or really bad psoriasis or even psoriatic arthritis as a kiddo, we have data on biologics down to like 2. So, I mean, for that reason, I think it depends. I don't like starting medications when someone doesn't need it. The way I think about it oftentimes is also like, what are that person's goals? And also, I also think about, like, how would I feel about having like a family member on this treatment? Like, do I feel like risks outweigh benefits? But for kiddos and adolescents, I think probably the same types of things apply in terms of, people might try to see if there is a hormonal flare, tackle that, some antibiotics to tackle the flares. But if it's really severe, I have adolescent patients who are on biologic therapies, and I think it's really allowed them to refunction. And so I think that that's something that pediatric dermatologists definitely, are able to see these patients. Just dermatologists, I'm not specifically peds derm, but I see kiddos and adolescents as well. Um, and in my opinion, we need to be able to do more trials that allow adolescent patients to participate, so that we're able to better know, like, what's going to happen. Because, for example, adalimumab, I want to just put out there for anybody who has a loved one, et cetera, Humira is approved down to age 12. So that's definitely a treatment that's FDA approved and easy to get to if somebody has moderate to severe HS and they're an adolescent.
Thank you so much for that. I also want to ask you a question about clindamycin. Do you recommend clindamycin 1% for mild HS?
Yeah, it's a good question, because I feel like it's interesting. The data for clindamycin 1% in the literature, and when you actually look at the research, it's actually not that strong, but it's given commonly. And I think for my patients, I've had sort of mixed responses. Some people really like it. They put it on when it's active. They feel like it does help shrink the lesions. And for people where it's helping, I'm like, that's great. Because the good thing about clindamycin topically is there's very little downside. So things that could help and have very little downside, I'm okay with. What I'm not okay with is if somebody has really progressive or moderate to severe HS, and the only thing they have access to is topical clindamycin. That's obviously not going to cut it, right? So I think for mild early HS, to try it is certainly reasonable.
Do you use specific antibiotics for specific flares? So, for an example, if you have a flare that's the size of a pea, are you using rifampin? Or if you have one the size of a golf ball, are you using a stronger, antibiotic? What determines what type of antibiotic you should take?
The data on this is not strong to guide us. I'm just going to throw that out there now. When we think about in general to use in HS, I would say probably the sort of rifampin / clinda, doxycycline, minocycline, those medications probably have more data behind them. But in terms of medications used for flare, it varies. And as far as I know, there's not currently any studies comparing like which combo is more helpful and why it was more helpful. What I would say is, I think a lot of factors that come into play is actually the patient or the person themselves. Like, they might have allergies that precludes the use of one or another, or they tell me that they've been on Doxy for 4 years and it didn't help. Like, I'm not going to choose Doxy. So I think that there's other things in the patient's history that can help, but in terms of guidelines, we just don't have that yet.
This is more a question related to, actually, this is a follow-up question because I was reading some literature about antibiotic resistance, and I think that's a great topic to segue into just because that is a thing that can be a problem for patients or for people who have HS. Can you talk a little bit more about that? And are there any antibiotics that we can take that don't cause resistance with prolonged use?
I think this is another sort of risk benefit assessment. Reason being, if I have someone sitting in front of me and they're suffering and they have a ton of drainage, I'm trying to find the right biologic. I haven't found it yet. And antibiotics are helping to allow that person to have less drainage, less pain, and be able to go about their daily activities. I'm sorry, but I'm just going to prescribe it to like help the person sitting in front of me. As a specialty looking like far and not just an individual in front of me, of course, I would love to be able to get to a place where I can prescribe less and not contribute to rise of like superbugs, et cetera. But I will also say that there are conditions for which longer term antibiotics are used for prophylaxis purposes. And, for like certain tuberculosis or other things are used for 9 months at a time. So although I'm sure my ID colleagues don't love it when I have to use antibiotics more or stronger, et cetera, like I think to help ease suffering while I'm trying to get to a place where I don't need it as much, I'm willing to do it. And I feel like with the goal in mind being trying to get off of it, I think using what you need to in the moment is okay.
Thank you for that. This question is kind of, it's not about treatment necessarily, but it's about triggers. What influence does stress have on the body? And then, with that being said, like on HS flares and symptoms specifically, does that vary from person to person? If so, what is the science behind that?
Well, I definitely think stress can play a role in multiple different sorts of like skin conditions, whether it's HS or eczema or psoriasis. Um, I think the mind, I think there's a connection with the mind body. And for me, I think looking at specific pathways, we don't necessarily have all the molecular pathways to explain why, but certainly stress is commonly listed as a trigger beyond like the sort of more physical triggers that we see, like the friction and the sweat and the heat. But I would say stress is among one of the top triggers that's reported. And I think that's why also thinking about like the emotional well-being and mental health aspect of how someone is doing is so important as well. And, oftentimes we hope that when we treat the HS and it gets better, that the mental health aspect will improve along with it. But sometimes there's other things that might be going on that need addressing separately too.
How do you know when a biologic is working? Are there signs that patients can, or people with HS or physicians can even look at?
Yeah. So I think it's really important to have an idea of like how to measure treatment success. Because if we can't think about what sort of like milestones we're trying to look for, then even if we're improving, we may not know that and we may stop a treatment too early, for example. I think that it's reasonable with a biologic to really think about it again around 3 months, just because we're also seeing some of the data come out showing that like even past 3 months, sometimes 6 months, you can see medications holding their efficacy or even improving. So really at least trying to give it a 3-month trial, I think would be fair. And again, I think we're not looking necessarily for scars or tunnels to disappear, but looking for a decrease in flare frequency. Hopefully flares are not as severe as they used to be. Hopefully drainage and pain on an average level have gone down. And then if you do flare, it's sort of like more quick to resolve. So, I mean, I think other measures would be if somebody really wants to be able to like ride a horse again, and they're able to, like getting back to doing something that you haven't been able to. It's another marker for success.
Are you able to qualify for Humira if you've had TB in the past, tuberculosis?
That's a good question. So if the tuberculosis has been treated and you've been monitored with like x-rays, et cetera, and a lot of times infectious disease colleagues will weigh in on this. But yes, The answer is yes. You can have had exposure to TB. But the reason we screen everyone for it before we start Humira, or you should be screened beforehand, is you don't want to have TB, not know it, and then because you are decreasing the body's inflammatory immune system a bit, to have the tuberculosis become too active. So that's a reason why we screen. So we can treat if we find it, but then that doesn't preclude someone from starting.
What does combination treatment look like? For an example, scheduling a surgical procedure and taking medication. What benefits does that have?
Yeah, so combo therapy is, I think it's the way to go, really. We have different treatment modalities that are available to us, and a lot of times having them together can be helpful. And I wanted to actually get Mario's take on this, because I feel like Mario, you've had experience with medical, surgical, like, do you feel like sometimes combination can be helpful?
Yeah, for sure. Yeah, definitely. Yeah, I think, I had surgery, CO2 laser surgery, and then I got on biologics and antibiotics. But yeah, I think if doing all three for me has been, kind of indispensable, right? One was make sure that, and plus the surgery has been 100% effective in the areas that were treated. So that part of it is promising.
Yeah, I feel like that can be really helpful. And
Yeah.
one important thing too is that a lot of times the medicines you're on, you don't have to stop it in order to get surgery. So that's an important point, because I don't want people to not get a procedure because they think they have to stop and they have to flare in order to qualify. They've done a study looking at people who were on adalimumab or Humira and got surgery, and found that staying on the Humira, actually people had better outcomes, and there was no increased risk of infection or bleeding or complications. So I think that's a really strong data to support keeping people on medicines while undergoing these, to keep the HS as calm as possible and have better outcomes.
Are there medicated body wipes at all for HS patients or people who are dealing with HS?
There's actually clindamycin 1% wipes. So it comes as a swab. So if you like the swab format, that's one that you could get. And then, if it's like a lot of sweating that you want help with, they also have anti-sweat sort of pads. So I would say that those are two type of medicated wipes that could be considered.
Can you swim in a pool with open lesions? And is it true that chlorine can help with flares? Is that safe?
I've had patients swim in pools, not with like necessarily giant wounds post-surgery, for example, but like if a couple lesions are open, they've gone into a pool and felt that it was okay. I would say it's different if it's the ocean, which may have maybe like a little bit more contaminated from like a bacteria perspective. So I think it's up to the person, because I've had a couple others tell me that, it kind of stung when they went in. And so I think it's up to the person's comfort level too. But in general, the great thing about pools is that you have the ability to swim and move without that excess friction that you would get on like a treadmill or walking. So I definitely like that aspect of pools in terms of reducing friction with exercise.
Are steroid injections used in flare-ups? And does being in remission from HS decrease the need for biologics? I think that's what this question is.
They're asking if biologics, if you get your HS better, will it help other things like PCOS or heart disease?
Okay.
I think that's what they're asking. And then the steroid injection. So yes, I'll start by saying steroid injections are used in flare-ups, commonly for inflamed sort of bumps that are painful. Injecting a steroid inside over the next few days or week, the bump hopefully will be less painful, less swollen, and shrink. And then it's a really good question whether or not treating the HS with a biologic can help other things like heart disease or other sort of comorbidity questions, other sort of comorbidities. The answer is we don't know right now. We need long-term data to show benefit in other conditions. I think when I think about it, thinking about having less systemic inflammation overall and potential benefits, I could definitely see why it could, but we need the data to support it to be able to say it.
About biologics in pregnancy, is that okay to take biologics while you're pregnant?
It's a really great question. And I think one that needs more attention. It's actually an area that I'm really passionate about because a lot of people with HS are, women of childbearing age. And so currently the most sort of safety data for pregnancy is for the TNF class. So that would be the adalimumab or Humira, or then infliximab or Remicade, those types of medicines. They have longer safety data and more numbers of patients supporting that use in pregnancy has not been shown to be linked to increased risk to the baby. There's another TNF blocker. It's called certolizumab. So certolizumab, the reason that I bring it up is because it is a TNF blocker that actually is in a very limited way crosses the placenta. Like it almost just doesn't cross the placenta. So in terms of safe biologics to use during pregnancy, I would say certolizumab would be one of the safest. The reason it's not brought up as much in the context of HS is just because there's not as much data specifically on certolizumab treating HS, unlike with, adalimumab or Humira and the Remicade and infliximab. So I would say absolutely, if somebody is on a biologic and they are planning pregnancy or they get pregnant, et cetera, it's a conversation to have with a clinician because there are definitely people who have been able to keep their HS calm through pregnancy on a biologic and delivered healthy babies. But it just needs to be monitored and a discussion in terms of risks and benefits, et cetera.
What connection is there between HS and PCOS? Does one influence the other? I know that PCOS is considered a comorbidity with HS.
Yeah, so there is among people living with HS or female patients, there is an increased risk of having PCOS. It's higher than if somebody doesn't have HS. And for me, it probably just ties back into sort of that hormonal or metabolic drive that we see with HS. The good news is there's some medications that can sort of target both at the same time, and some of them would include spironolactone or metformin. But certainly, I think that when we think about, again, women becoming pregnant, et cetera, PCOS, if you have PCOS, it could potentially impact fertility, for example. And so I think that these are all sort of related in a way when it comes to family planning, what medications to choose. So it's really helpful if you're a female patient with HS and you have like really irregular periods or, sort of severe acne that flares with your period or excess hair growth, to talk to your provider. And it could be that you have PCOS and medications are needed to help, for example.
I have a question for Mario from the audience. The clinical trial that you were in, was it
Mhm.
just a clinical trial, or did they make you change your diet and other things as well when you participated?
Um, no, they didn't, but I did. But I wasn't able to take like any antibiotics, very limited steroid injections. So in that regard, they're very strict on what you can take. But in terms of diet and using Hibiclins and Vicks and everything in the toolbox, good to go.
And Dr. Hsiao, um, if there are patients or people with HS who are experiencing issues with their dermatologist, finding someone that they can trust and that's reliable, what are some resources that can be used in order to find a specialist and someone who is on the patient or the person affected with HS's side?
I think that, being able to find someone that you connect with and that you trust is so important. There is the HS Foundation website does have an HS specialty clinic finder website where you can look to see the state you're living in to see if there's an HS specialist around where you live. And I'll put that in the chat. I think HS Connect also has resources in terms of providers that have sort of been vetted by other patients. But certainly I would say that if the connection that you're feeling with your current provider isn't the right one, to maybe I think that's a benefit of having these local support groups and things like that to ask who people have been seeing, or changing to a different dermatologist to give someone else a try. Because, I think it's in areas where you want to feel comfortable showing your provider, you want to feel comfortable talking about what you're going through. So it's really important to find someone, and not everyone is the best for everyone, so it's good to find someone that you connect with.
I have one last question. I want to wrap us up. Is Remicade a higher dose of Humira? Is that why it's an infusion rather than in an EpiPen like distributing device?
Yeah, it's a good question. Like, why is it not just in a pen? Why does it have to be infused? It's the way I think this medication was made for infusions, and the tests done on it were done as an infusion. Some medications can be infused or injected. The doses that people get with Remicade can get pretty high. But it's a good question as to like why there's not like a pen version. And I wouldn't necessarily say it's a stronger version of Humira, but I will say that you can get to higher doses just because you have that sort of dosing flexibility. It's weight-based, and also you can also shorten the frequency when you write for it. So yeah.
Thank you so much, Dr. Hsiao. Thank you so much, Mario, for your time and your knowledge. Thank you for your patience as well. And thank you for answering all of these questions. I appreciate your time. Thank you so much.
Thank you.
Thank you so much for having me. Take care, everyone.
Thanks, guys. Bye-bye.